Good afternoon and welcome to HFA's first Dateline Live event. My name is Sanja Wilkes. I'm the Vice President of Policy and Advocacy at the Hemophilia Federation of America. And it's my pleasure to welcome you today, and we're very excited for this first Dateline Live and hope that everyone gets a lot of information, resources, networking, everything that you need to be your own best advocate through the next 3 days. So with that, I'm going to turn things over to our President and CEO, Dr. Sharon Myers, to say a few words. Thanks, Sharon.
Thank you, Sanja. So thank you for being a part of our first ever Dateline Live event. And I'm sure you know, HFA publishes a very popular product guide issue on our printed monthly magazine, Dateline. And many people in the community have told us that it's an incredibly useful guide that sparks a lot of conversation about current and emerging products. And we've been thinking about how to take that printed information and build on it to create a robust conversation about products, important topics, and the challenges ahead. So we created Dateline Live as a segue from print. And I hope you find tremendous value in the information presented. A big, big thank you to our incredible speakers and volunteers for Dateline Live. And I personally cannot wait to learn from your insight. Thank you to our wonderful sponsors who believed in Dateline Live and chose to support it. Your partnership is truly valued. Thank you to our outstanding policy and advocacy team at HFA, Sanja, Miriam, Kimberly, and Mark. Your expertise, vision, and love of this community shows through in everything that you do. You've done an amazing job putting Dateline Live together. You've taken a very complicated print-based issue and made it easily digestible. And also thank you to our entire HFA team for supporting this endeavor with your time and amazing talent. Ultimately, HFA's goal is to provide timely information so you can make decisions about your own care. So with that goal in mind, let's get started. And Sanja, I'm going to turn it back over to you. Thank you.
Thank you so much, Sharon. And as Sharon said, thank you again to our sponsors, CSL Behring, Genentech, Hemobiologics, Sanofi Genzyme, and Spark Therapeutics. We're really honored that you trust us with this kind of information for our bleeding disorders community, and really hope to learn more from you from the next few days as well. Just a few quick reminders as we kick off the second half of our programming tonight. All attendees will be in listen-only mode. So if you need to speak with our panelists and our speakers tonight, go ahead and use that Q&A feature that you see at the bottom of your screen. That's the perfect way to get in touch with our panelists and speakers. For anything else that you may need, go ahead and send a chat to us. We'll take care of you through the chat feature, especially if you need your wrap session links for later this evening. Definitely go ahead and send us a quick chat to let us know if you don't have that link handy. With that, I'm going to pass it off to our next panel. And we have a really fantastic panel for you tonight. As I mentioned earlier, I think if I remember correctly, this represents about 50 years or more of bleeding disorders experience amongst the 5 folks that you're going to hear from tonight. And I think really will provide a great perspective from a doctor, from a nurse, from a patient, and from a caregiver. Your moderator is Eric Gilbluski this evening. He is a caring, dedicated social worker from the Mary Gooley Hemophilia Treatment Center in New York. And it's my privilege to introduce you, Eric, and your panel.
Thanks, Sanji. Welcome, everyone. Welcome to this fantastic hour I hope to offer you. As you all know, as you chimed in here, this hour is going to be the Dateline Live session, shared decision making the most of the patient-provider relationship. Sanji was kind enough to introduce me, but in case you missed it, my name is Eric Gilbluski, and I've been the social worker over here at the Rochester Hemophilia Center, the Mary Gooley Hemophilia Center, for 11 years. As I look at my panel, I think the rest of you are all in much warmer states than me, but at least my sunshine finally came to catch up with the rest of you. But I do want to, before I introduce these 4 amazing people, I do want to give you all the attendees sort of a rough sense of what to expect. This will be a 1-hour open-ended panel discussion with these 4 esteemed experts. The hope is that we're going to address communication and collaboration between HTC providers and patients, as well as their families, and talk about the challenges and ways to hopefully make it better. So whether you're logged in and you're a new patient or a new family, or you've been doing this for years, but maybe have been having some struggles with your HTC, I'm hoping that after this hour, you'll come away with some tricks, some wisdom. If I'm doing my job right, after I'm done introducing my panelists, I'm going to stay out of the way. I might have some questions to kind of get some conversation going, but I really encourage, I downright beg my panelists not to behave themselves. I want y'all to interact with each other, play off each other, ask each other questions. You're all much more interesting than me, so please do just that. I may interrupt time to time. Has less to do with me being rude. Has more to do with the fact that I'm going to be like a bit of a traffic cop. There might be hopefully questions from our audience that I want to make sure they can merge in and be asked. Also, I'll be honest with you, Zoom has taught me that I'm every bit the clumsy dancer I've always known myself to be. So I will probably just step on toes time to time too. Don't take it personally. For our attendees, if you're trying to talk, please understand you will be muted. This is a webinar format. The only folks who will be talking will be the panelists. But I beg you also, please engage us. Use the chat function, connect with each other, comment on the session. If you do have questions, please use the QA function. I'm much more likely to catch it there than if I'm chasing the chat along. So don't wait till the end. If you have a question, throw it out there right away and I'll try to get to it as soon as possible. Okay? That's all I got. So I'm going to put my panelists on the spot one at a time. I'm going to call you out. I'm going to ask you to take about a minute or two to introduce yourselves. Cassandra McDonald, can you take a couple minutes and tell us about you and tell us your bleep disorder story in a nutshell?
Good evening, everyone. I'm Cassandra Campos McDonald. I am a United Methodist pastor living in New Mexico. My husband and I have 2 sons with severe hemophilia A and inhibitors. My oldest turns 25 today, Julian, and youngest is 15, Caleb. And, you know, it's been quite a journey with inhibitors and complications, and one having an easy time of it and the other not. And so I've been active in the community since we were diagnosed, and look forward to speaking with everyone on the panel today. Thank you.
Awesome. Cassandra, I got a lot of good questions for you. Will, can I put you on the spot? Can you tell us a little bit about your story?
Sure.
Yeah, of course. Oh, sorry.
Go ahead.
Sorry. All right, off to a good start. My name is Will Hubbard. At the top, Eric said it was 4 esteemed experts. It might be more accurate to say 3 esteemed experts and me. My main qualification is that I'm a patient, so I'm providing the patient half of the patient-provider relationship. I have severe hemophilia A. I live in Arlington, Virginia. I'm 25 years old, currently looking for a job, so if anyone has any advice on that, hit me up. I could keep going with favorite flavor of ice cream and shoe size, but those are most of the big things about me. I think my main qualification here is that I've had lots of interesting little health problems over the years, so I've had to bounce around to a lot of different specialists. I've got to see up close and personal how a bunch of different great people at different HTCs have approached that process of collaboration over the years.
And Will, I don't want to be contentious or argue with you, but you are absolutely an expert. You've got years of wisdom and life experience, and I'm really going to count on you, Cassandra, to really keep things authentic and really tell. I think our attendees will really hang on every word you have to say. Chris, can I put you on the spot and tell us a little bit about your experience? Our next 2 speakers, our panelists, are, my guess is you probably know them already. They've shown up a time or 2 in the community.
Well, to the point at the beginning, I think I might be the even more so than Cassandra's son. I think I've been in hematology oncology for over 30 years and the coordinator at the center at Children's National for 24, I think. So I've been around. I'm a nurse practitioner at a pediatric HTC and have had the good fortune to participate in the bleeding disorders community in a lot of ways. And I learn as much from patients and families as I could ever hope to impart. And so I look forward to learning how to be a better nurse coordinator from participating on the panel. So thanks for including me.
And last but obviously not least, Dr. Sidonio, could you tell us a bit about yourself?
Yeah, good afternoon, everybody. I'm Robert Sidonio. I'm a pediatric hematologist. I'm the director of the pediatric side of the HTC at Children's Healthcare of Atlanta. I've been here now for 7 years and previously was at Vanderbilt University. My research really started out in women with bleeding disorders. It hasn't ended in that, but certainly have expanded it. I have clinical trials in severe von Willebrand's and in hemophilia A with inhibitors. Most recently, Dr. Meeks and I co-created the Atlanta Protocol, a newer approach to ITI for hemophilia A inhibitor patients. And we have 2 clinical trials that we're, trying to enroll for, at the tail end of a pandemic, hopefully. So, and my sports allegiance has changed. So now I'm a Hawks fan here. That's the old Hawks logo. So sorry for you other fans out there, but hopefully the Hawks can take down the Bucks tonight. So hopefully you guys can watch that later tonight.
Well done. So as you can see, we've got a young man who's lived with hemophilia. We've got a mom. We've got a seasoned nurse practitioner and an awesome doctor and a friendly neighborhood social worker to boot. So, Cassandra, I do want to circle back since you started. I do have a question just to sort of get the ball rolling. You touched upon it, but I'm hoping you can tell a little bit more of your story. When I got to know you a little bit last week, it's clear that your family's had some experience in seeking help from an HTC that wasn't your home HTC. You had to go elsewhere to get an opinion because of some pretty grave and serious complications with your boy. Could you tell a bit more about that experience, what it was like for you and some of the challenges and opportunities that came from that?
Sure. My youngest son, Caleb, if there was a complication to be had with an inhibitor, he had it. Extremely high titer, not treatable for a long time. He's gone through numerous, like 7 ports, target joints, everything. He even developed an allergy to factor VIII, which is not a good thing, and a pretty rare complication within factor VIII patients, more so than factor IX for the allergy. And so our treatment center in Albuquerque, the Ted R. Montoya Treatment Center, has been phenomenal to us over the years. And they've been caring for Caleb since he was a baby, and he's now 15. But our one longtime treatment center director, Prasad Matthew, left many years ago and left a huge hole. Oh my gosh, it was pretty devastating for our community. But it has, it's better, everything's good now. But at the time, Caleb's inhibitor was just wreaking havoc on all of us. And without a solid director in place and interims, we were at a loss and realized, my husband and I were like, we need to go to Denver. We need to go. I talked to Sanja, I talked to a lot of people and said, we need to get a second opinion. Because our first son, he had a low titer inhibitor. It was textbook how to treat it. 1 port, 5 years, no big deal. If you can say an inhibitor is no big deal, but for us, it was, right? So I don't say that lightly, but for my both boys, it was day and night. But we realized we really need to go see Dr. Manko Johnson and Dr. Wong and see if we could get some help. But in doing that, we did not want to alienate the treatment center, even though it was really in flux with, not a solid director. And like most places, when you have 5 or 6 or 10 hematologists, you don't have that one person who is the expert in inhibitors, because not just any hematologist, no offense to any clinicians on the call today, but not just any hematologist can handle an inhibitor, okay? Because it is a whole different animal. And so what we did was my husband Joe and I went and had a meeting with the interim director, Dr. James McKinnell in Albuquerque, and said, look, we know there's a lot going on here. Caleb is kind of a nightmare. We really want to go and get a second opinion in Denver. And before we could even get it out of our mouths, he was like, yes, please go to Denver. And so right then it was, okay, so we've made a good decision. Now let's do it. Because for us, it was all about, we want to make sure that whoever outside of Albuquerque works with us for the betterment of our son. Okay, that was the number one thing. We wanted them to all play nice and be the people that could help everybody work together, because as parents of children with hemophilia, we have to advocate in so many ways. But when you are a parent who is not a clinician, who is not a doctor, and you're trying to, have some kind of control, you have to be careful and you have to be respectful and very aware of what is going on. So we went to Denver, and one day this question came in my mind, because there was like silence in the room, and that's never a good thing. And I said, is this like a peanut allergy? Because he was allergic to factor VIII. Nothing was working, allergic reactions all over the place. And in that moment, Dr. Wong looked at us and said, let's send him to National Jewish, which is a hospital there in Denver that also, so now we have a third provider involved in treating the allergy. So now here we were, out of state, working with two other providers, and thankfully, oh my goodness, this doctor, the doctor in at National Jewish said, let's treat this with Xolair. And the way that Hemlibra, and I'm not promoting a product or anything, but the way that has changed the community for people is what Xolair did for us years ago and changed our life. And had we not had the foresight to say, let's go and let's look for another opinion, I don't know where we would be, because as it is, my 15-year-old suffers from chronic pain, has trouble walking at times, and he hasn't had a bleed in several years, which is great. But had we not gone and gone down that road, because it wasn't easy, it was expensive, it was hard. And then like when we would be in the hospital, because there was one year when Caleb was in second grade, we were in the hospital all the time for every holiday, for every birthday. A lot of you know that story of yourself. And finally, it got to the point where when a doctor on call, a hematologist would be on call, you dread that, who's on call this week, right? Who's on service? And you would have to say, Dr. So-and-so, Dr. Boyu, have you talked to Dr. Wong? And then that's when feathers would get ruffled. And finally, we had a doctor in Albuquerque say, we need a roadmap. We need a chart. I mean, it was literally a chart. I adore Stuart Winter, who's in Minneapolis now, doing peds for children. But the thing is, we had to devise a plan so that all of these different centers, out of state, in New Mexico, in Colorado, would know how to do the next thing, instead of putting the parent in the middle of, I really need to make sure you call and talk to. But when you have to do it, you have to do it. It did get ugly at times, but in the long run, it sure worked out. It literally, this is not exaggerating, it saved my son's life. It saved my family because of the second opinion and the way that we, not knowing what to do, had to go about handling the care with other people. And it all comes down to being respectful, to being considerate, and to remembering the bottom line, which was the care of our son. So I hope that helps give an idea of where I come from. And believe me, it wasn't easy. It was like, herding cats. That's what Dr. Winter would say. And that's what it felt like. But you have to reel it in. You have to get control of it. And when your purpose is there, and the main goal is the care of your son or your loved one, your spouse, then it is worth every minute of it.
Sandra, I heard you hit upon so many tools in the toolbox there in your story, that the importance of listening to your inner voice, to be an advocate, to finding champions, whether it's Sanji and HFA to help lead you down that path, or to have your doctors advocate for you and like you said, help herd the cats. It's amazing. And also too, you were great too. You also talked about that diplomatic balancing act, between being assertive, not being aggressive, and which you don't want to alienate. You don't want to bite the hand that heals you necessarily, and you want to bring out the best in others. Thank you for that. As I hear you tell your story about seeking second opinions as a consumer, as a mom, I want to jump over to Dr. Sidonia or Chris, and there's another side of the coin, that the whole experience of second opinions, either being sought or seeking. Robert, can I start with you? Do you mind telling a little bit from the provider experience? Because there's a lot that maybe consumers don't know how the sausage is made with regards to second opinions.
Yeah. So, just as a little bit of background, I mean, I grew up in most of my life in South Alabama. So I was used to dealing with very rural locations. My dad was in the military. And, I went to relatively small schools in Alabama. And so, when I moved, I always said I'm never moving to Atlanta, like we all say in the South, and then that's where all the jobs are. So that's where you end up. But, every region, they have a number of regions. Ours is Region 4. And, in that region, there's usually one or two big programs. And I think, I don't know if it's written or it's, implicitly stated, but we all feel like we're here as a center of excellence, and we want to help the smaller centers that may not have the resources. Maybe they don't have the 340B income to be able to pay for all of the experts, all of the people that are part of our program that don't generate any revenue, that actually probably lose money for the hospital. And so that's where, that 340B revenue is important to make sure that we have, a good rounded set of care. And so we're available, we try to be here to have all the big clinical trials available. And certainly Colorado also does the same in that region. I think nobody would argue that they aren't the dominating program there. But we sort of see ourselves as the place. We have regional meetings in which we meet with all of the providers throughout the region. We actually discuss difficult cases, try to get advice. And I think that's nice because then later, they feel comfortable reaching out to me. And we always say, if you need help, any assistance, we're here to make that happen. And so just recently, a couple of weeks ago, we saw a very complicated inhibitor patient that was having extensive bleeding and was being appropriately cared for, but was having unusual complication. I won't really get into it. I don't want any of the drug companies making me have to report something. But anyway, I mean, it wasn't that the care wasn't good. It was definitely adequate. And so, I think it was important that we offered that. And it's very difficult from state to state, particularly patients that are under Medicaid. It takes a lot of work. And that's where the social worker really plays a large role in ensuring the 1,000 pieces of paper that have to be completed before that patient steps in the clinic. I had to fill out all of the labs that I was going to send, how much I might bill for the patient, how many visits it's going to be, and whether they need any other resources that are, that we wouldn't be able to compensate for. And so, so obviously we're not here. I wasn't here to make money off that visit. I don't care about that. But, we were able to see the patient in 2 visits, be able to diagnose them. And it required significant laboratories expertise. So we were able to do labs here. We sent labs off to Children's Hospital LA. And I was able to communicate with Guy Young on this patient as well, because he had been also involved in this. And, we also had our research lab. So we enrolled them in a study so we could be able to do additional studies. And so all of that, obviously was a lot of effort, it was probably a good 20, 30 hours of work. But ultimately, it was what we like to do. We said, we went into this to be like the hemophilia detectives, Dr. Meeks and I. And so, the joy that we get out of it is that we helped them figure out what was going on. We came up with a plan. And the whole time, the 2 providers that had been seeing them in Florida were totally on board, because I had talked to them before, offered advice. And I said, we're going to help come up with a grand plan. And I told the family, but all the day-to-day stuff, the bleeds, you need to go talk to your local doctor about that. If they have any questions or concerns, feel free to reach out to us. So we sort of set up a clear guardrails of where the care should be. And, and nobody's ego really got in the way on this. I mean, they were very, the providers were great down there. It was definitely very complicated and certainly an above average complicated patient. And so, obviously we needed to help them out. Thankfully, we were able to figure it out and then obviously come up with a plan. They'll probably come back. But, the main thing is that we offered a plan and then we let the local center implement it. And, obviously opening up the communications, and anytime the patient reaches out to me, I always tell them, well, is it okay if I talk to your provider about this? Because I don't want, them to feel like they're left in the dark. And so we've done this a number of times. So I've been on the receiving end of that mostly with myself and Dr. Meeks. So we're happy to make that work. And I know Maryland definitely does that. Michael have that sort of same philosophy. So I think every region, you should look in your region. If you go to the CDC websites, you can look at your region. I know, Chris, what you're in region with 3? I don't remember which 3. Yeah, we're in region 4. There's a 4 North and 4 South. I forgot what Cassandra's region is, but those providers all talk to each other. And so, it's important that, that communication. So don't feel like it's, you're a burden or you're doing anything outside of, as long as you sort of say why I feel like I need the second opinion, and then, ask who it could be, because I've seen some patients when I was at Vanderbilt go get a second opinion for someone I thought it was, I really felt like I really wish they had talked to me, because I would have offered them a much better person to go see, so they don't waste all of their time and money seeing somebody that probably isn't going to be able to figure it out. Because we have our little group of people that certainly we trust, the Guy Youngs, the Marilyn Manco Johnsons, the Amy Shapiros, Diane Nugents, all these people that have been doing this for, as long as I've been around. And they have a lot of, and I don't think patients often realize that we actually send emails to each other and are happy to do that to save patients the trouble to, be able to visit, because oftentimes telemedicine has to be initiated as a second visit, not a first visit.
Sure. That's a really important point you bring up. I think sometimes patients and parents think that their hematologist is just operating in a vacuum. It's like a cowboy show, one-on-one. But truth is, there's no vacuum here. There's collaboration among the actual HTC team. And then I really love how you talked about the importance of the collaboration that occurs across HTCs in the regions and across the country. That applies.
Yeah, it's a team effort to get the patient seen, for sure, and make sure everybody's happy, make sure my hospital's happy, being compensated, that kind of stuff. So
no, it's not just doctors, it's social workers as well. I got buddies from San Francisco to Seattle to Maine, and if I'm stumped with a psychosocial issue, I got a team of experts I can rely on. So this extended family of HTCs really is in everyone's service.
It's a small group of people, so it's a small world, so we all know each other from meetings, right? So
a very tight community. Cassandra, good to have you back. I was a little worried about you there. Chris, I don't want to leave you in the dark. Do you want anything you want to piggyback on what Dr. Sidonio said as an esteemed provider yourself?
Yeah, I think, I think Robert makes a lot of good points about some of the HCCs that have a lot of resources, but I also would put in a plug for what's the smaller guys. We're not a big center, but, sometimes geographically we're more convenient for a family, and we do have a lot of expertise. So don't feel like you have to go to an enormous center. We can also access answers, and sometimes the reason for getting a second opinion isn't because you're the most complex patient in the world. It's because this is new to you and you want to hear a different perspective. And so I strongly encourage people to do that. We saw a little guy this week who was seen at another HTC in our region and just really wanted to hear what we thought about circumcision and activities and comfy caps, and and I think that's a good thing to do. And it doesn't mean they need to transfer their care to us. But it's important to sort of do your fact finding. And, we certainly share patients amongst HTCs if somebody needs to come to Children's because they need a particular cardiac surgery and they're coming from another HTC. That's another reason that we see patients. And like you, Eric, I have nurse colleagues all over the country. And, you know, when one of my patients is going off to college, I'm like, oh, that's where so-and-so is. And let me give her a call and let her know you're going to be in the area. And I like that. There's a reason for the HTC network, and, you know, sort of sharing that expertise and putting those feelers out there is something that you want to tap into as a great resource for care, whether it's something simple or something really complex.
Thanks. Will, you've been very patient, but I'm gonna put the spotlight on you, man. You're 25, you're the youngest of the panel here. You know what it's like. I believe, and correct me if I'm wrong, you started in one HTC as a youngster, and once you became a quote unquote grown up, albeit one who's looking for a career right now, you changed HTCs, is this correct?
Yeah, and letting the cat out of the bag, my first HTC was Children's National with Chris. So I'm always very nice to Chris because she knows where all the skeletons are buried, and she has tons of embarrassing stories about me from my childhood. But yeah, so I was with Chris, you know, all through elementary school, middle school, high school. And then when I went off to college, I did sort of a half transition. I always joke that Chris sort of had to shove me out the door because I'm just such a huge fan of her and the team she has there. But so I was going to school in William & Mary, so still in the state of Virginia, but much closer to the Richmond HTC. And so I established contact with them, went in for a checkup, signed all the paperwork for Chris to exchange information with that team over there. And then not long after I got to college, I had quite a bad injury. I went up to try to catch a Frisbee, and another guy who went up for it also landed on me. And my hip was just killing me stupidly. I hadn't made good contact with the school disability accommodation, so I was up 3 flights of stairs, which wasn't exactly ideal for that. And it wasn't clear, is it a bleed, is it a sports injury, is it some combination of the two? And so at that point, I really started working with Chris and with the Richmond HTC. And it was sort of this weird intermediary point because the Richmond HTC had all my medical history, right? But Chris was actually there when that medical history was unfolding. So Richmond was my first point of contact for like, hey, what's a good physical therapist in my area, right? Considering I don't have a car. You maybe know more of the people I should reach out to in Williamsburg. But then if they had questions about my medical history, sometimes I would tell them to go to Richmond, and then Richmond would say, can we go to Children's National, because we want some clarification on something in here. And so it really was this collaborative effort. And something I learned very quickly on in that is if you take a Venn diagram between any specialist field and hemophilia, right, there's some overlap between their area of medicine and hemophilia. And the people on the HTC side will have spent much more time in that overlap than these specialists, right? They know about the overlap between internal medicine and hemophilia more than someone in internal medicine who's like, oh no, I have someone with hemophilia. And so there was dialogue on both sides, and lots of it was just whizzing over my head, right? This is something I learned very early on, right? I am an imperfect messenger if we're playing a game of telephone. You know, once a medical condition gets past 3 synonyms, whether or not I will remember it and pronounce it correctly is sort of a tail flip. So really being comfortable to let my HTC and the specialists I was working with, the sports doctors and the physical therapists, really work together and have that collaboration. But on the other hand, you know, putting my foot down when someone was saying something that was obviously incorrect even to me. Something I noticed was that other people who didn't have a background in hemophilia couldn't quite figure out what was going on with my hip. So they were very quick to default to, oh, it must just be long-term joint damage from the bleed. And I was like, I know that's wrong based on what a bleed feels like, right? And you can go to my HTC, they've done, you know, x-rays and they can back me up on this, but this isn't a bleed. And it just felt like because they were running up against a wall, their first explanation was, oh, it's this hemophilia thing. And there were some providers who wrote me off like that, and there were others who weren't. And I learned really quickly that everyone in the process has to be involved are open to learning things. Me more than the other participants, right? They've gone to school for a decade. They probably know what they're doing, but it's always going to be new stuff brought to the table in any collaboration. And just as a patient, being accommodating and helpful, but also firm as being sort of the bridge between those two worlds, I think is something really, really valuable. And then eventually, once I left Williamsburg, I bounced around again, and Chris was like, "You're a little old to be coming here, I think." And then I started going to the Georgetown HTC. And again, that was another transition, another game of telephone, another sort of process of getting to know each other and learning how people work. I think as a patient, that is really important, you know, cultivating that relationship with a new HTC. I don't want to get too far afield into the world of transitioning and all that, because that's another talk in its own right. But collaboration is just easier the more parties involved you already know. And so you don't want the first time you're calling the HTC up to be like, hey, you're like 6 months late on your annual appointment, like we never talk, we never text, you know. It's easier if you have that ongoing relationship to bring them into something because you know each other and they want to advocate for you, right? Everyone at the HTC wants to help you, they want to be in your corner. And that's just easier for them to do if they have been with you throughout this whole process, right? So I'm happy to answer your questions if anyone has any or clarify anything. But like I said, I'm a patient, so a lot of this collaboration goes on above me. I'm just sort of the messenger who's making sure the connections are being made and sort of stepping in if something doesn't seem quite right. And that's sort of how I see my role in this whole process.
And you're right, this is not a topic about transition. We could have a whole afternoon talking about that stuff. But again, because of your demographic, you do have certain challenges. Maybe by being a young man, a guy in his early 20s, a new provider might minimize your expertise, which again, I think you corrected me the other day. You obviously didn't come out of the womb 25 years ago with expertise, but you accumulated a lot over your years. And unfortunately, providers, whether they're a doctor in the ER or maybe a first-time relationship with a new HTC provider, they might minimize your strengths. It sounds like you held your own, and you had some backbone, and you spoke up for yourself. And I appreciate.
And I do think Will sells himself short, and self-deprecation is a little bit of his style, but you know he does carry expertise and experience that's important to all of us to listen to. So I hope that we're not talking over our patients' heads, that when we're collaborating, that we're including them in the conversation, because you know, whether it's a whole family when you're at a pediatric center or you as an adult, you should always be a part of that. And I honestly feel like my role as a nurse is to really bring that level of the number of syllables down to a reasonable level, which is tough to do in hemophilia. But you know, that really, you know, leaning on your nurse or your social worker to sort of take that medical lingo and make sure it makes sense to you.
Yeah, and I want to say that this is something, like I could sing Chris's praises all day, just as we could do a transitions talk, we could do why Chris Gelcher is an amazing nurse practitioner talk. But something that I felt really comfortable at Children's was even as early as, you know, elementary school and middle school, my parents were encouraging me, you know, be involved in your own care, right? Like, we're not going to be doing this for you forever. Stick that needle in your arm, do your own bleed log, get on the phone with that doctor, you know, yada, yada, yada. And entering into that, you know, is a bit daunting, and something Chris was so good at and the entire HTC team was so good at was just explaining things to me, even as a kid, and, you know, making sure that there wasn't a stigma and sort of asking questions and trying to figure out what was going on. Like when Dr. Guerrero wanted me in a study, he would explain, you know, what the study was, you know, why I was signing away, what the privacy associated with it and the permissions. And I think as a patient, like being unafraid to ask those questions is an important part of that, because, right, your job going into a meeting with a new doctor when there is this collaboration going on, like they'll have done some work behind the scenes, right? They'll have exchanged professional opinions and talked a little bit, but there's some things that might be said in a meeting that don't make that file that goes to the next meeting. And so as much as possible, you want to be able to remember some of this stuff so that you can act as that conduit if it doesn't make the notes, or it's just, you know, if it's something even prior to this collaboration where it's like, oh, they tried this medication for me and it didn't work. or, oh, my doctor says that this, this is a coagulant, I shouldn't be using this. Having that ongoing memory of things is important, and the only way that works is if you involve yourself in the collaboration.
Absolutely. Sounds like, again, I think both Dr. Sidonia and Chris, you guys are pediatric centers. The Mary Gooley Center is a lifespan center. We've been at it, we just celebrated our 62nd birthday, so we've been serving patients with bleeding disorders 62 years. So it's been, I think my fellow providers can say one of the fringe benefits of working in the bleeding disorders space is these beautiful long-term relationships we foster. And Will, even though you've moved on, so to speak, you left the pediatric nest, this relationship hasn't ended. You and Chris are still pretty tight. And it sounds like she counts on you on occasion for certain things and vice versa. And the community is still there. I think that's beautiful.
He went from figuring out why we wanted him to infuse to coming and helping with our infusion classes. So, yeah.
Exactly. I knew that, and I was hoping you were going to toot that horn. So awesome. This is a question for the whole group. Obviously, we're tired of talking about it, but the last year and a half has sucked for a variety of reasons because of the pandemic. How do you think the pandemic has affected, how's COVID affected the providers and the patient's ability to collaborate and communicate? I'm going to just open that up to let whoever wants to jump in. What opportunities, what challenges have come from that?
Well, I'll just demonstrate that this is my telemedicine suite. And I think one of the silver linings of the pandemic has been really leveraging telemedicine. And it's enabled us to, limit patients from having to drive in. For some HTCs, it's hours of a commute. For us, it's getting across the bridge, which might take hours. And actually we had a bridge collapse here today, which is going to make traffic even worse around here. So I think, opening up and setting up the infrastructure to do telemedicine has enabled me to see patients more often, to see them in their homes, which is great in terms of working on a home exercise plan or checking on doses and expiration dates for medications. So I think that's actually been a positive from the pandemic, from my perspective.
Yeah, one of the things that we learned about the pandemic and telemedicine is that, there's a big issue about Wi-Fi access. That's one thing we definitely learned. And definitely in our rural areas have terrible Wi-Fi access. And certainly in our poor inner city, we learned a lot of patients, a lot of them rely on their phones for internet access, which isn't that great to do, telemedicine. And so we definitely learned that was a big problem. The great thing about telemedicine is that, I feel like a lot of institutions have been screwing around trying to figure out how to make it happen. And pretty much within a month, they had to make it happen. Like they had a hard deadline, had to happen. They had to do it. Hopefully some of the rules will be loosened up. They were pretty strict before, and it's state by state differences. So I'm hoping like silly rules, like if my patient that lives in Georgia is in Mississippi at the time, I can't do that and bill for it. I mean, to be honest, I don't know how the hell they would know, but whatever. But I mean, like a lot of silly rules, like I can't see a patient for the first time through telemedicine. If it's been a certain number of years, I have to see them in person. So there's a lot of restrictions before that were thrown out. So I'm hoping that they'll realize, like the great rules, to getting to go alcohol. Hopefully some of those kind of things will stick around. So
sure. There is a great question actually in the chat. Before I get to it though, I do want to ask Will and Cassandra, have either of you experienced telemedicine from the patient or parent end of things?
I actually have a little bit. Anecdotally, my perception is that people are a little bit more responsive, a little bit more ready for things to come at them sort of sideways because we're all doing this virtually. I also had a telemedicine appointment with a new doctor, and it taught me some of the limitations of telemedicine. Going in, we were like, oh, we can do this telemedicine. And coming away from it, he was like, actually, I'm going to need you to come in. Just to establish that connection, there were just things we couldn't do over telemedicine. And that became apparent. So I think it's a great tool. I've certainly taking advantage of it during this now 18 months or so, by now. But it's not like a one-stop shop. And like Robert said, there are also issues with access to Wi-Fi that are an important part of that. And also issues with access to care, which I just want to bring up really briefly. Like he was saying, you know, can we build this, right? And it's sometimes easy to talk about collaboration in this very abstract way of just, oh, the best professionals and the best hospitals, but there are networks and there are different plans associated with various metals. I understand, you know, is it bronze, is it silver? And so that's definitely a component of this, which is, I'll stop talking because that's somewhat downstream of all of this, but I think it's important to keep in mind when we discuss it.
Well, you bring up good points. I mean, like many of the things that get prescribed by nurse practitioners and doctors, results may vary, and that's the same with telemedicine. Depending upon your Wi-Fi access or the experience you're having or the needs you have. And there's a question, the QA here that sort of piggybacks on this. Dr. Sidonio, Chris, have you all been able to do effective PT visits via telemed with your patients? Because that's pretty hands-on.
That's tough. It's sort of like trying to get blood work via telemedicine. That's a tough task. So, but I certainly think, you know, yeah, it's something that can be done because it's not like everything is being diagnostic, right? If you know there's a long-term issue, certainly, you know, they can visualize different exercises and such. Obviously, it's not going to be the same as in person, being able to do that. But certainly if there's a question, an interim question about an ongoing issue, there definitely is some benefit. I mean, I can tell you oftentimes if there's bleeding or not, we have our patients text us and email us pictures all the time. We have a shared email website, a shared email that we all get access to. So we're not giving out personal emails. But sometimes you will hear a patient describe something and they send a picture and it's like, man, I wish they just sent that picture to begin with. You know, we saw a kid that had an incredible joint bleed and he was very minimizing it like it was no big deal. But this joint bleed was quite amazing. And so we were able to react to it. So sometimes the visuals are much more important, but yeah, it is very challenging to do that, you know, via telemedicine.
And I do want to just give a few moments to this question. It's very important, a little off topic with regards to collaboration and communication, but it's still very important. I think it's worth putting it out there. Dr. Sidonio, I'll just put it to you. Renita asks if it's okay for, is the COVID vaccine safe for folks with hemophilia? Can you speak to that a little bit?
Yeah, and there's certainly, you know, you can go to the NHF and HFA and you can see the link there. And a number of bleeding disorder organizations have links on this. So early on when, you know, COVID, you know, was sort of ravaging the country, we were all concerned as providers whether they were going to be more susceptible to some of the issues. We certainly were concerned about the high risk of, you know, myocardial infarctions or heart attacks, blood clots, strokes. And so if you were a hospitalized adult patient, often we would give prophylactic doses of blood thinners. So something like heparin, warfarin, Lovenox, you know, versions of that. So certainly those are concerning drugs to give to hemophilia patients. So it's nice to have that context that, you know, that makes it very complicated to manage. And Chris can tell you, somebody has a blood clot and a bleeding disorder, that is not a fun thing to manage. It's very difficult. And our adult colleagues manage these commonly. But, you know, we've had a pretty good amount of data from Pfizer and the Moderna vaccines, which are the ones we primarily use in the United States. And there really isn't anything to suggest that these vaccines aren't safe for patients with bleeding disorders of any type. Certainly, people were very concerned when there were some reports from Johnson & Johnson vaccine, and that may be the one that you should consider. It's my personal opinion, if you're going to avoid a specific subtype, that may be the one to avoid. Very rarely have we seen an unusual complication from that vaccine, and patients can develop severe thrombocytopenia. It's called vaccine-induced thrombotic thrombocytopenia. And that's seen in the Johnson & Johnson Janssen vaccine and also in the AstraZeneca one. So these are mostly, we're seeing more overseas. Certainly I've heard of cases within the United States. And so those are probably the ones to avoid in our population. That's my personal opinion. And it's really important. People often will say, well, these vaccines were rushed so quickly. Yeah, well, when you have absolutely all of the red tape removed, we open trials in 4 weeks instead of 6 months, which it typically takes to open a trial. And you remove all of the issues that come with that, and there's rapid interest in enrolling, then it's not difficult to do a trial. And mRNA vaccines, I received the Pfizer vaccine, my entire family did. And so, the technology's been around for a while. It really wasn't anything that they were concerned about doing because it does cost a lot more money, but obviously that wasn't important right then. It was important to get the safest vaccine, to produce one that's going to have the minimal amount of side effects. So obviously that's your personal decision, but also remember, if you're an adult and you get hospitalized from COVID, you have an extremely high risk of developing a thrombotic complications, which is going to be significantly worse than the mild side effects that typically come from the vaccine.
And I would just add to that that we have seen COVID in pediatric patients that required hospitalization, and we've also seen a lot of what's the multisystem inflammatory syndrome in children, or MIS-C, and those patients also require anticoagulation. And these are kids that were previously healthy, that really weren't even sick with COVID, but were around somebody who had COVID, so had usually a fairly decent exposure to the virus, and then a month later get very, very sick and require anticoagulation. So, for adults who are eligible, our younger kids aren't yet. So, we are encouraging adults to get vaccinated, and our kids over 12. And one of the questions when you sign the consent for these vaccines is, do you have a bleeding disorder? And the reason for that is because it is an IM injection. It's not because there's a reason that you shouldn't get it. So patients on factor prophylaxis, we recommend that they get factor beforehand. Those on emicizumab, or mild bleeding disorders, we feel like that is not, the additional treatment's not necessary. But I would also encourage you to talk to your primary care providers and your HTC, who know you better.
Thank you both. Great advice. I am the timekeeper. We're wrapping up. We have about just over 5 minutes left, and I do want to give a few moments to Ray, who had a question. It might not be a fair question for our pediatric providers, but we'll put you on the spot anyway. Ray's asking, who's looking out at aging and all the new complications that we're running into? Older guys with hemophilia are having a hard time advocating for themselves. There's a long list of problems that we're running into. Could you guys speak a little bit to how the professional community is looking at aging a little bit?
Yeah, so Robert's involved. I was involved with Athens, and so is Robert. And I know one of the first studies we did as a community through Athens was a look at comorbidities in adults. And there is a lot of research out there. And there's a lot of collaboration about what to do for procedures like colonoscopies and, bypass and, stents and those kinds of things. So I think, just like Will said, in terms of, advocating for yourself and starting the conversation, I would encourage adults to sort of have those conversations and be a part of connecting your specialist, your primary care, and your HTC. And, I think sometimes the HTC sort of falls, the patients feel like their HTC is their primary care provider, but we're not, and we shouldn't be. But we certainly need to be a part of those conversations preparing for procedures. So I would, that Venn diagram that Will talked about, you need to get all those specialists in and think about bleeding disorder in the big picture.
Perfect. Well said.
I mean, we definitely are. That's, before, even 20 years ago, when I was looking at data at the CDC, there was a dramatic drop off after age 55 in number of patients in these certain things that I was looking at, including the female patients that are carriers. And it's because of the devastating effects of the 1980s, obviously. And so we're now, like Chris mentioned, there was a first Athens study focused on complications like high blood pressure. And there are a number of groups that are interested in things like high cholesterol. How do you manage and mitigate issues related to stroke? Obviously, we have to think about what's going to happen with gene therapy. You have a male that's had low factor VIII his entire life, and all of a sudden you raise it up into the 20-30% range. It may have been somewhat protective. And so it's actually a good thing because we're now telling people, particularly older patients that are starting emicizumab, those on gene therapy, you may have been delaying seeing your cardiologist, seeing your primary doctor, managing your blood pressure. Now it's time to do all those things as you get these newer therapies that are getting closer to normal hemostasis, because you may have had that protective benefit of having low factor VIII for such a long time. So
And
it's a
Ray
great
asked,
question.
where can you find that study? Do you happen to know off the top of your head?
Is it
The author-
Suman, right?
Is it Barb Kunkel is one of the authors?
Yeah, it's published. It should
It's-
be available online. Yeah, Kunkel and Sood, I think, SOOD,
Yeah.
right?
Conkle with a K. So,
Yep, Konkle.
perfect. Thanks,
Yeah,
Ray.
and you can go to the Athens website. They have listed
Yeah.
on there. It's the first Athens study. There should be the summary of the data there and probably a link. I know they've been doing that more. Yeah.
Awesome. So I don't want to be sensitive of time. I want to see if we can wrap up in a couple minutes here so we can give Sanji and the good folks at HFA time to break up the different wrap sessions. But I do want to circle back. Cassandra, you kind of started things off as the engine. I want to have you kind of end us as the caboose here. And maybe Will, you can jump on as well. Cassandra, what advice would you give a new patient or a family that might be struggling with collaboration with their HTC? What kind of words of wisdom would you put out there to help someone kind of solve some of these communication barriers they might be struggling with?
You know, it's all about, sounds really silly, but you just need to take a deep breath, because when you're living with hemophilia, any kind of bleeding disorder, and you're in the middle of what I call the worst of the worst, you have to remember that it's not about what's going to happen tomorrow. It's about breath by breath. What is happening in this moment? And sometimes that's all you can handle. But then as caregivers, we have to think about the what ifs and what happens if I go here or there. And it can be overwhelming. So you just have to take it, what's that saying about an elephant? It's one bite at a time or something like that. And so, it's about always keeping focused on what what is the important thing, my son, my daughter, my spouse. And even if it's as simple as making a list of what needs to be done, and then how am I going to get there? I'm very, very tactile and very visual. And sometimes it takes talking through the process with somebody else. And if you don't know another, and I'm speaking from a parent's point of view, of course, if you don't have another parent that can help you figure out the next step, that's when you contact HFA. You can email me, or anybody in the community. Go into a Facebook group if you know some people and say, I just need to talk this through. What do I do next? And it's like I said, it's about breathing. It's about being calm. It's about not letting our emotions get the best of us. And I'm sorry, me and Sanja have history letting our emotions get the best of us and not doing the best in the moment. But when you have those moments that you're like, oh my gosh, I was a complete, whatever you want to call me, to that doctor, you always come back and say, look, I'm sorry. This is my focus and this is what needs to happen. How can we get there together? It's about we, it's not about them. It's not about you. It's about we. How do we collaborate? How are we a team? Because you do not have to have an MD after your name or an RN. And when you're a parent, a caregiver, a spouse, to know what is best for your loved one. And so when you approach it that way and you have that good, you try to build that good relationship with your provider, that is the most important thing, because one way or another, an answer will be found. It just may take a while. It may take a lot of deep breaths. It may take a lot of tears and a lot of, fits of, I don't know what to do next, but always keep your focus and remember what the primary issue is my child, my loved one, and you won't go wrong. But if you need someone to talk through an issue, reach out. Don't be afraid, because no one journey is the same. Okay, there's not a manual for this. So every experience is different. And never, okay, whatever you do, never say, well, Cassandra, my experience isn't as bad as yours. But no, every experience is, your journey. It's not about comparison, that mine isn't as bad or it's not as easy. Okay, so just remember that what you're dealing with is a lot for you, and it's not about comparing. So anyway, I could go on, and I'll be careful. So anyway, just
Cassandra,
reach out. You're not alone.
Cassandra, you put an entire book's worth of wisdom in 3 minutes of advice. I appreciate that. Well done. Well, you know what, panelists, we're out of time. So I just want to thank you. Thanks, Will, Cassandra, Dr. Sidonio, Chris. You're extraordinary. I hope our attendees got a few nuggets of wisdom out of this experience. And thanks to Sanji and HFA for allowing us to do this.
Thank you guys so much. That was wonderful. I can't wait for the days that I can give you a hug after a presentation like that. It was really great. And Cassandra, you're right. Guilty as charged. Definitely have let emotions rule instead of knowledge before. So thank you guys. I really appreciate your expertise this evening. I want to say thank you again to our sponsors this evening, CSL Behring, Genentech, Hemobiologics, Sanofi Genzyme, and Spark Therapeutics. Really appreciate their support and glad that they were here with us for the next few days. So as we close out this meeting, in your web browser, there will be a quick 5-question evaluation that we're asking everyone to fill out. We really value your feedback at HFA, so please do take just a minute to complete that evaluation, and it should launch right as this meeting comes to an end. So here we are at everybody's favorite piece of a hemophilia or bleeding disorders meeting, and that's our wrap sessions. So earlier today, you received an email that had a link to your specific diagnosis room, if you will. So be sure, click on that link for your room. So Factor VIII, Factor IX, von Willebrand disease, rare and inhibitors are our wrap sessions this evening. So be sure to click on that. If you don't have your link, give me just a second, send me a chat message and we'll try and get that to you. But we very much appreciate everyone being here tonight. Thank you to our panelists. Thank you to our speakers earlier. And we look forward to seeing you again tomorrow. Be sure to pay attention to that email tomorrow morning. There's something you might want to print before we start our first session of the day. But we look forward to seeing you at 4 p.m. tomorrow. See you soon. Have a good evening and enjoy your wrap sessions. Good night.